Welcome everyone. Bill Saxon here. Happy to be spending this next hour or so together to kind of just review how we manage diarrhea, diagnose it, treat it, some of the common causes, and then we're going to kind of put an emphasis on how polymerase chain reaction testing can help us in certain patients that present with diarrhea. Okay, so let's just kind of jump right in to get started. And this is what we're going to be looking at, reviewing some of the common causes, leaning more toward young animals, but we'll cover diarrhea in all ages, how to interpret the signs we see to help us localize the problem and determine a differential diagnostic list. We go over, review the advantage that fecal antigen testing offers in detecting intestinal parasites. And then, like I said, kind of highlight the value of PCR testing in certain dogs and cats with diarrhea, looking for infectious causes, and then how to treat it. Okay, so here we go. In the United States, and I'm sure it's kind of worldwide, there's no surprise here that diarrhea is one of the most common clinical signs that patients present with. Luckily, most of, especially the younger animals that present with diarrhea have a relatively benign cause, a short course of disease, and a spontaneous resolution or with some supportive care. However, that's not always the case. And because there are so many causes of diarrhea, it can be helpful to kind of review how we approach these cases. And I think we'll just start with a case. I'm not sure if my video there is covering up some information. Maybe I'll just try to turn it off. I don't want to risk doing that. Anyhow, our patient today is Quincy. He's a 3-year-old neutered male Australian Terrier. He comes in with about a week's duration of diarrhea, large volume, watery diarrhea. And looking back into his history, he's had several accidents in the house. He's got a slightly diminished appetite. He's indoor-outdoor, as most dogs are. No witnessed exposure to any garbage or dietary indiscretions or toxins, no vomiting, and he's doing good on his monthly parasite prophylaxis. On his physical, vital signs are normal. He looks pretty good, but there is a slight degree of weight loss since his last annual visit. So his issues are 1 week of large volume watery diarrhea with some decreased appetite and mild weight loss. Again, a million potential causes of diarrhea and vomiting for that matter. So where do we start? Well, I think it helps by considering the age of our patient, with younger animals being more likely to have a dietary indiscretion, parasites, viral infections like parvo, or foreign body obstructions, right? They're curious, they're nosy, they're indiscriminate, right, in terms of what they put in their mouths. And then as we get older, we kind of think about maybe some extra GI or a process outside the gastrointestinal tract, as well as more primary GI diseases. So these would be things like metabolic disease, chronic kidney disease, for example, things like Addison's disease, neoplasia can do it, intestinal dysbiosis, inflammatory bowel disease. So in older animals, we often need to consider a wider range of potentially significant illnesses, and then correspondingly a more broad workup. All right, so I think for me, one of the first things I look at is the age of the patient, obviously the signalment, and that helps me kind of rank my differentials and what testing I'm likely going to do, if any, in a patient with diarrhea. The next step is to help us further narrow our focus on what we're going to be pointing our diagnostics and treatment at, is to determine if we have an acute problem or a chronic problem. An acute diarrhea can be defined as less than a week, basically, less than 1, maximum 2 weeks. Okay, just a one-time incident without recurrence of a short duration of clinical signs. And the good news here is most, especially young animals, dogs or cats that come in with acute diarrhea, have relatively benign problem and resolve either spontaneously or with symptomatic treatment. Okay, all of them get dewormed, as we'll discuss, and a few days worth of a bland diet. Some acute causes, though, are severe, like the acute hemorrhagic diarrhea syndrome, which we'll talk about, parvovirus, other infectious causes, and sometimes, foreign body obstructions, partial or intussusceptions, right? Those could be more severe problems. Chronic diarrhea, we define that as greater than 2 weeks, or episodic diarrhea that has occurred over a month or so. Okay, so maybe sort of transient resolution, but recurrence. Okay, and here, these are more likely to be primary GI diseases that require an extensive workup, like intestinal dysbiosis, inflammatory bowel disease, and others, or some secondary cause, a metabolic disease, an endocrine disease. Those sorts of rule outs would be on our list in chronic diarrhea cases. So we established whether it's acute or chronic, and the next step is to determine whether it's a large intestinal or small intestinal disease. And here we have to look at sort of the nature of the diarrhea itself, but also what else is going on with the patient. So the most reliable indicators of a small bowel process would be weight loss and hypoproteinemia. Okay, this, though, would imply that we have sort of a significant, if not chronic, process. And so in an acute patient, we might not see either of those findings. All right, and then we look at the nature of the bowel movements and the frequency of them. So with small bowel diarrhea, most often we're looking at larger volumes of diarrhea, sometimes watery, with a normal or low frequency. Okay, large bowel diarrhea, on the other hand, the most reliable indicators of a large bowel or large intestinal process are fresh blood in the stool, hematochezia, and mucus in the stool. All right, we don't always find those, and when we don't, then we look at the frequency and the nature of the stool. And here it's with a large bowel process, we're looking at small volumes of stool, more frequent defecations, and sometimes draining. All right, so we determine acute or chronic, large or small bowel, and we're kind of narrowing our focus on where we're going to investigate further. So let's put these criteria in play with Quincy to determine if he's acute or chronic and large or small bowel. Well, he's got diarrhea for a week. That makes him acute, and we don't have any history of previous recurrences. So I would consider Quincy having acute diarrhea. And then we look at, is it large or small bowel? And here we have large volume of watery diarrhea. So that is a criteria that best fits small bowel. And also this weight loss, mild as it is. So I think we're safe in assuming or concluding that Quincy has acute small bowel diarrhea. And that's going to help us as we go further. Okay, so what is our next step then in working him up? And these are, again, the list of possible diagnostic steps in a diarrhea workup. And again, I like to consider ranking them from what we do in all cases, and especially in acute cases, to what we might reserve for some animals that have more chronic diarrhea. So any animal that presents with diarrhea, no matter what age, size, history, etc., all get fecal examination for intestinal parasites, because we do not want to diagnose roundworms, whipworms, or hookworms on biopsy. Okay, these all, require a thorough evaluation for intestinal parasites. When they're sick, systemically ill, we want to screen for systemic disease or determine if the diarrhea itself has caused problems with electrolyte abnormalities, dehydration, azotemia, by looking at our laboratory minimum database, or CBC biochemical profile and urinalysis. Moving on to imaging, radiographs, or ultrasound. In certain more chronic cases, we want to investigate gastrointestinal function and pancreatic status, which we'll discuss. And then in a subset of patients, we're going to reach for PCR testing to rule out infectious causes or co-infections, so more than one infectious cause or parasitic cause in a patient. And then finally, if we're not getting anywhere with our less invasive diagnostic tools or symptomatic treatment, intestinal biopsy. Okay, so let's go. So all diarrhea patients need to have fecal examination for intestinal parasites, and we have multiple methods for doing so. And I'm going to list the 3 most common here that are available now currently. So the direct smear or wet mount, which is least commonly done and least effective, so we're not going to spend much time on that. Fecal flotation for sure. The key here is with centrifugation versus the passive flotation. All right, we'll talk about why that centrifugation step is important, and then the benefits of including fecal antigen testing in assessing for common intestinal parasites. Why is it so important when we do fecal flotation to use the centrifugation method? Because you're going to identify 10 times the number of parasites. Okay, so even if you extend the period of passive flotation to maybe 15 minutes, and by this point, you know, we're seeing the flotation solution crystallize, and sometimes we can't even get the cover slip flat on the slide for an even fluid layer. Even extending that passive flotation time, you're not going to cover nearly or discover nearly the number of parasite eggs, ova, as with centrifugation. This is really important. And our sort of leading source for all things intestinal parasites, the Companion Animal Parasite Council, recommends that flotation be done with centrifugation for this reason, detecting more parasites. There is a relatively new addition to our toolkit for diagnosing intestinal parasites, hookworms, roundworms, and whipworms, so nematodes, and that is fecal antigen testing, which is not testing for eggs or ova. It's a worm biomarker. So these are proteins. These antigens are proteins, coproantigens, that are secreted by adult nematodes once they're in the intestinal lumen. Okay, so this gets us around some of the issues we have with detecting intestinal parasites having to rely on identifying eggs in the stool sample, right? What would those be? Well, with egg detection, that only occurs after there's been a pre-patent period, right? So with hooks and roundworms, that's 3 weeks before we'll see any eggs in the stool. With whipworms, it's 3 months, right? So there's no way to identify, if we're looking for eggs, those infections in the early phase. With the fecal antigen test, we identify those infections earlier in that pre-patent period, because this is a test for a biomarker secreted from the intestinal parasite. Also, with egg detection, you know, you have to, for there to be an egg, there has to be male and female worms in the intestine. With the fecal antigen test, single sex infections can be detected. So the antigens will be detected whether it's a male or female. So that's helpful. We can detect single sex infections. We can detect pre-patent infections. And when we include fecal antigen testing with fecal flotation with centrifugation, we diagnose twice the number of intestinal parasites. This is also, using the fecal antigen is a useful way to determine whether we truly have a parasite in the patient or not. So let's say that we have a dog and we identify what looks like we identify a roundworm egg in that dog's stool sample. That roundworm egg could be due to roundworm infection in the dog, or it could be that the dog ate cat stool, and that is a feline roundworm egg in that dog stool sample. Something like 35% of dog stool samples have cat stool in them because they're such coprophagic animals, right? So let's say that we have this. We have a dog who has a roundworm egg identified on the stool sample, but has a negative antigen test. That negative antigen test tells us there's no adult roundworm in that dog. Therefore, that egg is a pseudoparasite. The dog just ate cat stool and that egg rolled right on through, and that dog does not need to be treated. So it can help us determine whether we truly have, the fecal antigen test can help us determine whether we truly have an infection in that dog or not. Okay, so this is a very useful tool to increase the number of positives that we're going to see when we're screening for intestinal parasites, hooks, rounds, and whipworms, and also can help us diagnose the infections earlier. Remember, some of these intestinal parasites are zoonotic. So roundworms and hookworm are zoonotic parasites. If we can detect the infections in the dog, for example, in the pre-patent period before eggs are shed, then we can treat that infection and eliminate egg shedding, environmental contamination, which could pose a risk to humans, okay, in the area. So very, very useful tool to have in the kit. So let's look at Quincy's fecal flotation and fecal antigen test results. Looks like he's negative for hooks, rounds, and whips, but he's positive for Giardia. Okay. Quincy's positive for Giardia. Is that it? Do we have our diagnosis with Quincy? Well, it turns out that Giardia is not that simple of a matter, right? An issue. So we're going to just kind of review the current thinking about the relevance of finding a positive Giardia test in a patient. And the screening test of choice, by the way, for Giardia would be the SNAP test for Giardia, the ELISA test. It's much more sensitive than looking for the cysts or the trophozoite on a stool sample. Okay, anyway, Giardia, is it important or not? This is a big debate, and it was considered a normal pathogen, a normal commensal until the 1960s. Most animals and humans that have Giardia are not symptomatic. It's the most commonly misdiagnosed and overtreated intestinal parasite in small animals. So many things can trick us into thinking we're seeing Giardia on that stool sample, pollen grains, some related organisms, right? It's very, very difficult to confirm a diagnosis microscopically. And this is, of course, a disease that's most commonly contracted when we ingest infected cysts from contaminated water. Unlike most of the other intestinal parasites, Giardia cysts are infective immediately upon shedding. So think about hookworms, roundworms, and whipworms. The eggs are not infectious. Those eggs have to larvate, and that takes 3, 5, 7 days for those eggs, once they're shed, to become infective. Think about toxoplasmosis in cats. It takes a day or two for those cysts to become infective cysts. So one of the keys therefore is to just do daily stool cleanup, because if we pick up stool on a daily basis, there's no time for eggs in that stool sample to become infectious forms, and we eliminate any risk for reinfection of the patient we're dealing with, other animals, or people when there's zoonotic parasites involved. With Giardia, the cysts are infective the minute they're shed. So where are we at now with thinking about clinical Giardia cases? So our CAPC, that Companion Animal Parasite Council, now recommends only testing symptomatic animals. We don't want to screen asymptomatic patients for Giardia because we will not know what to do with positives, and we're only treating animals that are clinical. All right, so there's been a change in the emphasis we put on Giardia. It's a test that we do only on symptomatic patients, and those are the only animals that we treat. One of the concerns and one of the reasons a lot of us are sort of concerned about Giardia and testing it in our patients is the concern of its zoonotic potential, which we don't need to really worry about, to put it simply. So there's, at least in North America, there's never been a confirmed case of zoonotic transmission of Giardia from a small animal to a human being. And the reason for that is each species has its own Giardia, the subtype or assemblage, all right? And they don't tend to infect other species. It is true that human assemblages have been found in dog feces, but it's likely that the dog ate human stool. Okay, so if one of the reasons you're testing patients for Giardia and treating asymptomatic patients for Giardia is because you're concerned about zoonotic potential, that is no longer considered a good justification for doing so, okay? It's hard to diagnose this for sure looking at a stool sample. In fact, I'll just put it out there. Most parasitologists these days recommend not wasting technicians' time trying to find Giardia on a stool sample because it's really hard. Even when the technicians are told there is Giardia in the sample, a minority of them are able to identify it. It's that hard. So again, we in the clinic for sure, we rely on doing the Giardia SNAP test for the most accurate way of identifying this pathogen. When we do need to treat, and that's only when we have clinical patients, we want to give a combination of fenbendazole and metronidazole. You can see the dosages here, and you might repeat that after your initial 5 to 7 day period. If the patient's still clinical, it's likely there's some other cause of clinical signs that is associated along with the Giardia in this patient, but one option would be just to repeat both drugs for a longer period of time. And at the same time, we want to give ancillary treatment to optimize gut health that may help the dog's our cat's own innate gut immune system clear the infection. So that would be adding a fiber source and a probiotic. And the key also is, because these cysts often get trapped or caught on the hair around the perineum in the patient and can reinfect the patient. They're infective as soon as they're shed. One important aspect of treatment is to bathe the patient, especially around the perineum, to prevent auto reinfection, and clean food bowls, water bowls, toys, bedding, just to make sure there's no cyst that could reinfect the animal. If you want to assess whether you've successfully treated the patient, which is not necessary if clinical signs resolve, if your patient responds to treatment, there's no point in retesting. But if that's something that you're thinking about doing, don't wait any longer than 2 to 3 days to repeat the SNAP test after your course of therapy, because the longer gap between when your treatment ends and when you do the SNAP, there's a very short, pre-patent period in this organism. So the longer you wait, the greater the odds of reinfection are. And so you wouldn't know if you get a positive, say 2 weeks out, if that was an unsuccessfully treated infection or reinfection, no longer than 2 or 3 days. But again, retesting is not necessary if the animal signs resolve. Okay, now, one of the things in the States, anyway, one of the motivations that veterinarians need to test asymptomatic patients for Giardia is if these animals are going to be used in, say, daycare centers or for companion purposes in nursing homes or hospitals, right? Those facilities want the dogs to be proven negative for Giardia, thinking erroneously that there's a zoonotic potential. Now, I will say, obviously, never say never. If you are dealing with immunocompromised patients or very young or very old patients, there's a potential, I suppose, that Giardia could be a zoonotic threat in those instances. So sometimes here we just have to test, right? So here's what we do. You test. If you get a positive, you treat that same protocol for 5 days. You do all the ancillary therapy we talked about, and then you test 1 day after you stop, and you just like cross your fingers and hope you get a negative. You show that to the facility and you're good to go. Okay. All right. So Giardia was positive in Quincy. Are we done? Okay. So again, with Giardia, is it really the only cause of signs in a patient? Is it the cause of signs at all? Often we know that it can be concurrent with other more significant causes of diarrhea. Are we going to stop, treat Giardia and Quincy and move on, or what are we going to do? Well, there's no right answer to this, but I'll show you what Quincy's veterinarian did do. Quincy's veterinarian included a diarrhea PCR panel, and the reasons for that, why in Quincy's case would we just not treat for Giardia, deworm prophylactically and see what happened, which is an option. In Quincy, his veterinarian was concerned because Quincy wasn't quite the healthy, normal, young dog that has sort of a benign cause of diarrhea. He had that decrease in appetite. He had that mild weight loss. So Quincy's veterinarian was worried about some underlying or co-infecting process. Also, chances of other parasites were minimal because Quincy's owner was really good about administering the monthly prophylaxis. And, the vet wasn't sure, because the stool was so watery, whether there was a good enough sample to identify other parasites on the fecal flotation and fecal DX test. So we ran a PCR panel on Quincy for those reasons. Perfectly normal, acceptable, adequate approach. And before we talk about the results, let's just review a little bit about polymerase chain reaction, why it can be so helpful when we're trying to diagnose infectious disease of any cause, right? So what it is, obviously, is a test that looks for mostly DNA, sometimes RNA of the pathogen, and it's super sensitive and specific, meaning that if the organism is in the sample that you draw, when you draw it, chances of the PCR missing it are very slim. False negatives are very uncommon with PCR testing, the way it's done at IDEXX. And then because we're looking for a specific segment of DNA that is known to be in that specific organism, PCR testing is also very, very specific. So it has the advantages of high sensitivity, very few false negatives. You're unlikely to miss the organism if it's present in the sample when you draw it, and high specificity, meaning very few false positives. If you get a positive, you've got your bug, you got the answer. And another advantage of PCR to say serology, another common way we diagnose infectious diseases is you can often detect the disease earlier than serology. It takes on average, say, a week or two for serologic tests for antibody to become positive, where PCR, you might be able to detect that infection in the first week or so after exposure, okay? Now, real PCR involves a amplification of the DNA. So we run it through the machine 45 times, 45 cycles, with the DNA in the sample doubling each cycle, meaning that at the end of all of this, you've got trillions of copies of DNA, which is the reason why it is so sensitive. PCR, the way we do it, can detect as little as 10, sometimes only one organism in the sample. So really very, very sensitive. We also have the ability to quantitate the amount of DNA in a sample, which is really helpful clinically, because the amount of DNA or RNA that we recover can help us determine whether we need to treat the animal or not. So some vaccines, for example, modified live vaccines, will also be picked up by PCR. Think distemper. Got a puppy who comes in showing clinical signs of distemper. He's also or she's also in the middle of the puppy vaccination series for distemper. You want to test the dog for distemper. If you get a PCR test, right, we know that that distemper vaccine will be picked up by the PCR test. How do you know whether it's the vaccine that caused the positive PCR or infection? Well, there's where the quantitative PCR comes in. We've established a cutoff. Above a cutoff, a higher amount of DNA indicates infection. Below the cutoff, a lower amount of DNA indicates vaccine, because vaccines will cross-react, but with a lower number of copies than a true infection. So that's one instance of where quantitating the PCR can help us as veterinarians determine whether we need to treat or not, and also can be helpful in determining whether our treatment has been successful if the number of DNA copies comes down, for example. So how do we interpret PCR? We've kind of gone over this already. If you get a positive, you got the answer. Okay, the organism is there. It's up to us as veterinarians to determine if that's the cause of the clinical signs, but you've got the organism. A negative, because this test is so sensitive, a negative usually means you do not have the infection you're testing for, the organism you're looking at. However, like we've said, the organism has to be in the sample you draw when you draw it. And sometimes that's not the case. Think with vector-borne disease. Organisms don't circulate in the blood for very long. After an acute period of circulation, then the organisms hang out in the spleen or the liver or the bone marrow. So if you happen to draw blood for, say, Ehrlichia and run a PCR in a chronic Ehrlichia dog, you're likely to get a negative. It doesn't mean the dog doesn't have Ehrlichia. It's just not in the blood when you drew it. And sometimes, because these PCR tests are so specific for a given strain of an organism, say for FIP, the FIP virus now, we have a test for a spike mutation in the coronavirus in cats that is only found in the pathogenic coronavirus, the FIP coronavirus, right? That's a very common mutation that occurs that causes FIP, causes the transformation of the benign enteric corona to the pathogenic FIP coronavirus. That's one mutation. It's a common one. It covers most of the strains of FIP in North America and Europe. Well, not every mutation involves that gene, right? So if this particular FIP strain has a different mutation than the spike mutation, then the test won't pick it up. So you see what I mean. A negative usually means you don't have the disease. It can mean the organism's hiding or that the strain is mutated. Okay, so all of that said, by far PCR is the most sensitive test for infectious disease in any animal, okay, compared to serology. And the quantitation can help us as veterinarians determine whether we need to treat. A higher number of gene copies or DNA copies is more likely to be of clinical significance, i.e. the organism is causing the signs, and then we can monitor the response to treatment using quantitative PCR. And there's a whole raft of them here. Some of them have to do with diarrhea patients, for example. You could consider doing Clostridium perfringens NET E and F toxin gene PCR if you're concerned about having a dog that has acute hemorrhagic diarrhea syndrome, what we used to call hemorrhagic gastroenteritis, and we'll talk about that in a minute. So useful to have these quantitative PCR tests, and they're available for any number of diseases. Another example of where quantitative PCR is really a game changer is in how we stage and manage FELV infection. All right, so just as a real brief summary, cats that have FELV exposure can clear the infection. All right, so that would be an abortive infection. They're not infected, or they can become infected. Once they're infected, they can become progressively infected. In other words, the immune system wasn't able to control the disease at all. So the cat develops clinical signs of FELV. It's infectious to other cats. It develops FELV-associated diseases and has a shorter lifespan. Or if the immune system is able to mount somewhat of a response that's able to control the infection in the DNA of the cat, that's called a regressive infection. And in that case, that cat is not infectious, it's not sick. So how do we determine whether we have a progressive or regressive infection? We do a quantitative FELV PCR, and a higher amount of virus indicates progressive disease, a lower amount before the established threshold, below the established threshold indicates progressive disease. Total game changer. Okay, so when do we use PCR in a diarrhea workup? These are the indications currently. Okay, so we've got sort of a sick patient, systemically ill patient. We would not do PCR routinely on a puppy or kitten that comes in looking great, eating, drinking, hydrated, and has acute small bowel diarrhea. Okay, when we have a more ill patient or a chronic patient, or we have these conditions where we've got acute bloody diarrhea, systemic illness, any sign of, say, sepsis or systemic inflammatory response syndrome. So we've got low neutrophils, fever, all those indications all those signs would be indications for considering PCR. Animals that are on raw or contaminated diets, where we might be concerned about salmonella, for example. When we have an immunosuppressed client and we want to be sure in our diarrhea patient, we don't have any organism that could be a threat, a zoonotic threat to our client. When we have diseases that are refractory to treatment, let's say that we had treated Quincy for Giardia and hadn't gotten anywhere, right? Gave him a couple rounds of therapy and he still has clinical signs, classic indication for getting a diarrhea PCR panel. Maybe there is a co-infecting infectious cause, as there was, as we'll see in Quincy. And then also we can use this to monitor response to therapy. So let's look at Quincy's PCR results. And again, Quincy had PCR run because he wasn't the good, healthy looking diarrhea dog. He had some weight loss. He had a decreased appetite. Though he was Giardia positive, the veterinarian astutely decided to screen for co-infection and found cryptosporidium as well. So had we treated Quincy just for Giardia and not seen a response, this is why, co-infection. So his veterinarian was able to diagnose this early and get Quincy on appropriate treatment for both Giardia and crypto quickly and get him resolved. And this is the key thing again about Giardia. Often we treat Giardia and we don't see a response, and we retreat Giardia and we don't see a response, and we retreat Giardia. We get on this cycle, and more often than not, if you've gone through 1 or 2 treatment cycles for Giardia and the patient still has signs, look for something else. Rule out other infectious causes with PCR, and then look for other causes of intestinal tract disease or secondary disease affecting the GI tract. Okay, it's super common that the Giardia may be present and not causing signs. Okay, all right, so treating acute diarrhea. Let's talk about how to treat our patients once we've figured them out. Obviously, if we find a parasitic cause or an infectious cause, specific therapy aimed at the organism. In general, with mild cases, appetite's good, not dehydrated, we send them home, bland diet, we deworm them all, and then only use an antiemetic if they're also vomiting, right? That makes sense. We admit acute diarrhea patients who are sick. Okay, the classic indication would be a dehydrated patient with decreased appetite who's lethargic. And here we just want to support them. Primarily reestablish normal fluid and electrolyte balance. If they're vomiting, Cerenia or Meropitant for their antiemetic drug, stay away from or avoid the tendency to use empiric antibiotics and GI protectants in these patients. In the vast majority, not necessary. I think these drugs are very frequently overused to the detriment of our patients, and I'll explain that. And then gut rest while they're in the clinic, followed by introduction of a bland diet, and then gradual transition back to their normal diet. Okay, this would be an acute cause of diarrhea that warrants hospitalization, the acute hemorrhagic diarrhea syndrome, and this was formerly called HGE, hemorrhagic gastroenteritis. All right, this is a disease that most often affects young to middle-aged small breeds of dogs, and they look really good when they come in most of the time. It's surprising, right? So because they can often have this disease and yet look good clinically, it's tempting to not investigate for it when these small breeds come in with this problem. So I always recommend in any dog that presents with diarrhea, and sometimes vomiting precedes diarrhea in this condition. So any dog, especially a small breed dog that comes in with either vomiting or diarrhea, I always recommend at the very least getting a PCV and total solids to rule this disease out. And I'll explain that on the next slide. So again, comes in, clinical signs classically is acute onset, vomiting often precedes diarrhea, but when they do get diarrhea, it's sort of bloody and it's cut some mucus, and we call it like a raspberry jam type diarrhea here. And the cause of this now has been determined to be Clostridium perfringens strains that produce these toxins. So there's a gene, the NETI and the NETF genes, that are genes that code for a pore-forming toxin that causes the intestinal issues, the necrosis, inflammatory infiltrates of the intestinal tract that lead to the clinical signs in this disease. And this is part of our diarrhea PCR panel, and it's most often seen with this disease, not with chronic diarrhea, not with parvo, and not with normal dogs. So when you have a young dog that comes in and you're wondering, what is this? Is it acute hemorrhagic diarrhea syndrome? Could it be parvo because it's bloody diarrhea? This test will help you differentiate the two. So again, the PCV total solids in any small breed dog that comes in with vomiting or diarrhea, acute onset, even if they look good, they often do, is highly recommended to investigate for this disease, because one of the diagnostic criteria is hematocrit, elevated hematocrit with normal total solids. So you're looking for a hemoconcentration. If you do additional testing, you might find that there's a left shift in your leukogram, so an inflammatory leukogram. If you do a biochemical panel, liver enzymes may be increased, mostly due to hypoxemia, perhaps due to toxin or inflammatory mediators in the portal circulation from our leaky intestinal tract. These guys can be hypoperfused, so they might have an increased lactate. And if we run our diarrhea PCR panel, we'll find that they're positive for the NETI-NETF gene. Treatment here is just pour the IV fluids at them. They can often require high dosages of IV fluids, and you administer until you get that hematocrit down to below 50. Once you get them resuscitated, get their volume back up to normal, get them looking good clinically, then they often have a need for potassium supplementation in their fluids. And the new paradigm in treating this disease is to only use antibiotics if they have signs of sepsis. So they're febrile, they have brick red hyperemic mucous membranes, their neutrophil counts are low, their glucose might be low. So any signs of sepsis, or they just aren't responding to fluid therapy only. And the reason for avoiding antibiotics is because they do have some, negative aspects to them in terms of affecting the normal flora in the intestinal tract, and they can actually lead to overgrowth of bacteria species that can produce toxins. And then obviously indiscriminate antibiotic use can lead to antibiotic resistance, which we're trying to avoid. If you're going to use antibiotics, then something that is going to be effective against both gut anaerobes like metronidazole, as well as like E. coli and gram-negative organisms like a fluoroquinolone or a third-generation cephalosporin would be the ways to go. Okay, so just to go a little bit into more detail about when we would reach for antibiotics with acute diarrhea, if we have a specific organism that requires it, okay, if we have the specific condition called antibiotic responsive diarrhea, which we'll talk about in a minute, if we have an immunocompromised animal that has a zoonotic pathogen, right, we want to help clear that pathogen before we get issues with our human counterparts, right? If we have diarrhea with blood and any signs of sepsis, as we talked about here. So low neutrophil count, high band count or toxic change in the neutrophils, both of which indicate systemic inflammation, fever, hemorrhagic feces, blood in the stool, and shock. Okay, these are the indications for antibiotics. The reason we don't want to throw antibiotics unnecessarily at patients with diarrhea is because we can actually worsen the clinical signs by affecting the gut flora. Sometimes we rely or we're using drugs like metronidazole and Tylosin, we think more for their anti-inflammatory or immunomodulatory effects than for their antibacterial effects, but there's questions about how truly immunomodulatory they are, okay? Obviously, we were concerned about antibiotic resistance when we give these drugs unnecessarily and the development of pathogens that could be a concern for humans, like methicillin-resistant Staphylococcus aureus. To get more information about when to use antibiotics and the concerns about indiscriminate use, this is probably our best resource to date, a consensus statement around the rational antibiotic use in diagnosis and treatment of diarrhea in dogs with chronic diarrhea in dogs. Highly recommend taking a look. Okay, if Quincy hadn't responded so well to his treatment for his acute diarrhea and became chronic, let's talk about how we deal with chronic diarrhea now. So if we've got chronic small bowel diarrhea, we first want to determine if we have maldigestion, and this is basically exocrine pancreatic insufficiency, or malabsorption, which can be protein losing or not protein losing. And malabsorption causes are more common, and these are things that we routinely think about and have to deal with in older patients with chronic diarrhea. So this would be things like inflammatory bowel disease, dysbiosis, lymphangiectasia, lymphoma. Cats that have hyperthyroidism or other non-GI diseases can affect the gastrointestinal tract and lead to chronic small bowel diarrhea. Okay, so these are the things we're going to be doing additional testing for. And the common rule outs for these causes of chronic small bowel diarrhea would be dietary responsive, fiber responsive diarrhea, antibiotic responsive diarrhea, whipworms, and the fungal infection is more likely large bowel, and then any sort of chronic enteropathy, intestinal dysbiosis, inflammatory bowel disease, or infiltrative neoplasia, most commonly lymphoma, especially in cats. So what is this antibiotic responsive diarrhea we keep talking about? Well, it's a recognized form of chronic diarrhea, and it's caused by intestinal dysbiosis, right? This is a disease that we kind of back into after excluding all other causes and having no response to any other treatment, right? If we decide that's what we're dealing with, then our two options are prednisone, okay? And some dogs will respond to prednisone alone. If we do reach for an antibiotic for this antibiotic responsive diarrhea, Tylosin is preferred these days over metronidazole. And the thing to keep in mind here is that this is something to warn the owners we might have recurrence. And if this recurs, then we would continue to explore other options, other rule outs that might be leading to the recurrences, something like inflammatory bowel disease, small intestinal or large intestinal neoplasia. All right, so what are our diagnostic steps that go beyond the ones we use for acute patients? Well, here we kind of need to for sure evaluate for systemic disease, hyperthyroidism in cats, low protein to determine if we've got protein losing enteropathy, and high calcium level on your chemical panel, biochemical panel, which might indicate lymphoma, those sorts of things, right? Imaging is going to be a big help, and we'll talk about that in a minute. And we have these other tests for GI function, pancreatic function, and inflammation. We've talked about PCR already, but in these cases, we absolutely want to rule out all infectious causes, and the diarrhea PCR is the way to go. And eventually, if we're not getting response to less invasive treatments, getting a biopsy to see if you've got underlying neoplasia or some condition that would require specific therapy. So imaging, I think if we had to pick one, ultrasound is going to give us the more useful information in the majority of cases, including identifying obstructions, okay? Younger animals who are prone to foreign body ingestion, radiographs are a great place to start. In general, the information you get from radiographs and ultrasound are sort of, they complement each other. So start with radiographs is what we most often do, get ultrasound. But again, if you had to pick one test, one imaging modality to give you the most information, it would be ultrasound. Don't think there's any surprise there. Do thoracic radiographs have a role in intestinal disease patients, diarrhea patients? Absolutely. Screening for concurrent chest disease or metastatic disease in our chronic patients, looking for esophageal involvement, and also looking at the chest to see if there's evidence of hypovolemia, microcardia, a narrow caudal vena cava. That could be our clue to lurking Addison's disease, hypoadrenocorticism, which can be very sneaky and present in a lot of ways. And so that might be a clue there. Okay, we absolutely don't want to miss megaesophagus when we're dealing with GI patients, especially when we have a history of regurgitation. So just chest radiographs do have a role here, but abdominal imaging for sure takes the precedence, has precedence, and ultrasound is, as you know, very, very useful in determining whether we have obstruction. Here we have the concentric circles that are likely and indicate intussusception, and useful. Ultrasound is also useful for confirming pancreatitis in our patients as well. Okay, so speaking of pancreatitis, when we're looking at chronic diarrhea patients, we have two things to be concerned about. So pancreatic function, do we have the lack of function and therefore exocrine pancreatic insufficiency, maldigestion, or do we have pancreatic inflammation, pancreatitis, that is irritating adjacent bowel causing diarrhea? Always like to point out useful resources for practicing veterinarians, and the ACVIM consensus statements are open source documents that sort of highlight the state-of-art diagnosis and treatment of a lot of common things we see in practice. And there is a recent consensus statement on feline pancreatitis, which covers it all from what causes it to how to diagnose it to how to treat it. Highly recommend it. And the upshot is that in clinics, a combination of some pancreatic specific lipase, like a SNAP FPL or CPL, and ultrasound are the best, most reliable diagnostic tools we have. Nothing is perfect, but when it comes to pancreatitis, the best we got these days is the pancreatic specific lipase and ultrasound. When we are considering whether or not a dog or cat has pancreatitis, we want to first screen with a sensitive screening test. And that's where our SNAP tests come in. And a negative test rules out the disease. A positive test, any positive screening test needs to be followed up with a more confirmatory test with a positive SNAP for either FPL or CPL, so feline pancreatic lipase or canine pancreatic lipase. Confirmations required. Two ways to do it: send a sample to the lab to get a quantitative number, how high that FPL or CPL is with a spec FPL or CPL, and then abdominal ultrasound. Okay. The test, by the way, for exocrine pancreatic insufficiency, do we have pancreatic function abnormality, is T as in Tom, LI. So TLI is the gold standard test for exocrine pancreatic insufficiency, and a low value confirms the disease. With pancreatic disease, in cats in particular, or small intestinal disease involving the ileum in dogs or cats, often cobalamin is decreased because cobalamin is absorbed in the ileum. And in cats, when cobalamin is ingested, it has to get to the ileum to be absorbed, to be reabsorbed. and it has to be protected from bacterial utilization in the stomach or degradation in the intestine in order to reach the ileum intact to be absorbed. An intrinsic factor is what protects it from bacterial degradation or digestion in the small intestine prior to the ileum. In cats, the pancreas is the only intrinsic factor is only produced by the pancreas. In dogs, the stomach and the pancreas produce intrinsic factor. In cats, only the pancreas. So if you have a cat with pancreatitis, i.e. the pancreas isn't functioning normally, because with inflammation comes lack of function, intrinsic factor production goes down, and that makes the cobalamin more likely to be digested, degraded before it gets to the ileum. So cats with pancreatitis in particular are at risk for low cobalamin levels. All right. So this is an important thing to monitor and measure when we have chronic diarrhea or pancreatitis, especially in cats. Because a low value of cobalamin, especially if that's combined with a low albumin level, carries a poor prognosis. When we intervene, we don't wait for the cobalamin level to be below the normal, below the low end of the reference interval. That's too low. Okay, most of the cobalamin is intracellular. So we don't wait for the serum level to be below normal, because that means the total body cobalamin is already depleted, right? So we treat when they're at the low end of the normal reference interval, below 400 nanograms per mil, and we can use either injectable or oral cobalamin. And the reason that oral works is because there is some absorption of cobalamin throughout the intestinal tract. Most is absorbed in the ileum, and it's recommended, especially in sort of chronic patients who might have weight loss and decreased protein levels, to begin with injectable, because that always works. And then if that does work, you can maintain them on oral cobalamin if they need it. If, in other words, if the underlying disease is treated and corrected, they might not need ongoing cobalamin therapy. But if they do, once you've got the levels up to the desired range, well within the normal interval, you can't have too much. So if you repeat your cobalamin levels on the serum and they're high, not a problem, right? If you're there, then you can consider switching from injectable to oral. Finally, if we're not getting anywhere with any of the other diagnostics, we would need to get down to getting biopsies. Cytology can also be helpful, especially with chronic large bowel diarrhea, doing a rectal scraping or aspiration of focal lesions, looking for fungal diseases, looking for neoplasia. If we find any fluid in the abdomen, we can also consider fluid analysis, looking for, is there bilirubin, is it septic, And then when it comes to biopsy, we can do that endoscopically for mucosal biopsies, or getting full thickness biopsies either through laparoscopy or laparotomy. I will say that when we do endoscopy, we want to do both upper and lower GI endoscopy. So scope both ends in all patients, because even if an animal presents with just diarrhea, they might have diffuse disease throughout the intestinal tract involving small intestine and stomach, right? So conversely, if an animal presents with just diarrhea, with just vomiting, that might indicate to us clinicians that we have a gastric or small intestinal problem. There could be large bowel involvement as well. So scope both ends anytime you scope a patient, and get biopsies from multiple sites. And if you do a laparotomy, an exploratory, because you're not getting an answer, doing all your less invasive tests, you don't come out without having biopsied multiple sites within the intestinal tract, any lymph nodes, maybe even liver, maybe even spleen. If you're going to go in, you're not coming out without biopsy tissue. All right, so I think we've covered most of what we need to talk about when it comes to diarrhea workup and treatment. And we're just going to recap the indications for when you want to consider PCR testing in a diarrhea patient. So we're looking for infectious causes or genes of organisms that can cause toxin production and lead to diarrhea. We want to consider PCR in these instances. All right, acute bloody diarrhea, you got a systemically ill patient, animals eating a raw or contaminated diet, there's stress or crowding conditions where infectious or parasitic causes are more of a problem, when we have any zoonotic concern, when we have a dog or cat that's not responding to the one organism we think we have. We want to determine if there's a co-infection, as in our patient's, our Quincy's case. And then we can also use especially the quantitative PCR to monitor response to therapy. And these are just sort of the broad categories of infectious agents that we can identify: by bacterial causes, viral, parasitic, and the enterotoxins that are associated with acute hemorrhagic diarrhea syndrome. And with that, thank you for your attention, and I hope you have an enjoyable rest of your day. Thank you so much.
Até este momento pode ser qualquer coisa. O tutor disse, ele está letárgico, está diferente, mas é preciso mais informação. Por isso, os laboratórios de referência IDEXX oferecem os testes mais inovadores do mercado. Preenchemos lacunas com soluções exclusivas que revelam detalhes ocultos. Descobrem doenças mais cedo. Enxergam o que os outros não conseguem. E estamos sempre criando mais. Só com o mais avançado e completo menu de testes, você poderá montar o quadro mais completo dos seus pacientes. Descubra mais com os laboratórios de referência IDEXX.